Okay, the last one, systemic sclerosis. Okay, so I got to make it fast. For me, again, this is an argument. Is it a T or a B cell? For me, MS is a T cell. B cells are involved, but you got to target both. So systemic sclerosis, my view is it's an autoimmune vasculopathy. Okay, and because the biggest organ in the vascular system is the heart, for transplant, it's the heart that matters in this disease. Unlike MS, unlike Crohn's, the key in this disease when you take them to transplant is the heart. It is, in my view, an autoimmune vasculopathy, and so the skin gets tight. Here's how you can grade the skin on the Rodman skin score, but here is the vasculopathy, the nail bed. People don't look at nail beds anymore in America. I don't know why. But if you look, you see the normal architecture totally gets distorted, drops out and becomes distorted. It is a vasculopathy in the nail bed and in the heart. In the capillaries, in the small venules, it becomes totally distorted. You get tissue ischemia, you get ulcers, you get contractions, you get fibrosis of the skin. But it is, where I lay the main blame is as an autoimmune vasculopathy, and I can have LUTA with scleroderma specialists about this all the time. Of course, you want to, there's other factors involved. But for a transplant, that's the key. And the truth is, look at the nail bed, okay? And you can see the vasculopathy. It jumps right out at you. Okay, this area right here. Put a drop of oil, take a look, or there are now programs you can put in your computer and you plug the probe in and you can put it right here and it shows you on your screen and you can record it. And you compare it to after transplant and it improves. The vasculopathy improves. It improves with the skin score and the joint function. So anyway, so a brief history. These are again, I'm staying because we don't have time with just my studies. 2011, we reported a randomized trial in the Lancet. 2013, we reported everybody done in 2 centers in Chicago and in Ribeirão Preto with Giulio Voltarelli. So this was reported in Lancet from USP and from me. I had given Giulio my protocol and they ran it there with a slight change. We didn't CD34 select, and it's not necessary in this disease to do it, unlike Crohn's, for longer remissions. So, and then finally I reported in 2021 a cardiac safe way of doing it in bone marrow transplant. Now, why cardiac safe? Because again, for me as a transplanter, when I look at this disease, obviously I'm looking at the skin and the contractures that are so important and limit your lifestyle. I look at pulmonary function, of course, and the pulmonary artery hypertension. The key for me is the heart, and I will get to that. Okay, so in our first trial reported in Lancet, we randomized HSCT, Cytoxin, ATG, no CD34 selection. Again, we stopped our ATG dose at 6, versus monthly IV cyclophosphamide. And if at 1 year you didn't improve on the control arm with monthly IV cyclophosphamide, you could cross over to transplant, okay? Now, at 1 year, virtually everybody did cross over. So looking at this randomized trial beyond 1 year is hard to do because virtually everybody crossed over. But you could then look at what happened on the ones that weren't doing well on Cytoxin as they crossed over. They became their own controls. So, the candidates had to have a skin score of more than 14 and either lung, heart, or GI involvement. And they virtually had all of that. Here was our regimen: cyclophosphamide, ATG, first dose, lower dose, less fever. And of course you have to give Solumedrol with each dose, stem cells here. And here's our results from that first trial. Now, in blue is this first group is modified skin score, and blue is the transplant group. Just by randomization, they had a worse skin score, and they got better by 1 year. The group that got monthly IV Cytoxin, standard of care for scleroderma, their skin score worsened by 1 year, okay? And then if we look over here at FVC, blue again got transplant. Their FVC improved. Biggest jump was at 6 months, then kind of stable. The group that got monthly Cytoxin over a year, their FVC worsened. And we could show that in all lung parameters. And importantly, when we crossed them over to transplant, which is this dotted line, so they got worse, they crossed over to transplant, they got better, okay? Now, not only did we look at the total lung capacity got better, DLCO that got better, FVC got better on the transplant group compared to the monthly cytoxin, and skin score that got better, and of course FS36 got better. It didn't on monthly cytoxin. We actually quantitated the volume of lung disease. So there are programs that do that. The computer, you just have to put into the program the Hoytsfeld units that it is to consider as disease, which is the brightness. And then you outline the areas it should not consider, like you take out the liver here or spleen here, and you tell it that the rest of the area can count. So here's pre-transplant. I think this 6 months or a year later, you can notice the improvement. But in fact, when you have the computer do it and look at volume of disease, which it shows here in the different lungs, compared to post, it's 926 mLs of diseased lung versus 446 a year later. That's shocking. None of these drugs out there, and there's very few for scleroderma, really are thought to improve lung function. And these did. The transplant did. So when we took then, all the patients got transplant because almost everybody in the control arm crossed over at 1 year. You can see the skin score for all of them markedly improved over time. The FVC got better, stayed better. The DLCO, though, didn't improve. The total lung capacity improved. So why does FVC, total lung capacity, improve and volume of diseased lung, I just showed you the study, improve, but the DLCO does not improve? That bothered me, and I thought when I submitted this paper, a reviewer would trip me up on it because I didn't have an explanation, but they didn't ask. But it bothered me, and that led me to the next study where we continued doing this, but we then also added what they were doing at USP in Ribeirão Preto with Julio and Carolina, and it's 89 patients. And to date, this is the largest transplant trial ever reported in scleroderma, 89 patients. The European randomized trial was 78 patients on the transplant arm, so here we have 89 reported back in 2003. And when we look at them, here's, I think, the skin score, modified Rodman skin score, marked improvement, and it subtly continues to improve, even out to 5 years. It keeps improving. Here, if we look at, I think, this is FVC, it's improved. When we look at DLCO, here's total lung capacity improved. But when we look at DCLO, it's not improved. It's kind of all over the place. So again, it's the same thing, but with a larger number of patients. So I just broke this down, and lo and behold, if you look at something so simple as an EKG, any patient with scleroderma we took to transplant had a normal electrocardiogram, their DLCO improved after the procedure. Those in which the electrocardiogram was abnormal, even flipped T waves, which is very, very common with scleroderma patients, it never improved. The reason they didn't get better was because of the heart. And so I began reading up on DLCO because I had naively thought only the lung and, of course, the amount of hemoglobin in your blood determines DLCO. So we always looked at corrected DLCO for hemoglobin. But no, cardiac output, cardiac function plays a big role in determining DLCO. And that's the problem. Once the heart is showing evidence of disease, the DLCO didn't improve, despite the volume of disease in lung improving and the skin score improving, quality of life improving, and FVC improving. Now, in fact, we've done more elaborate studies, and they're just at abstracts, but one paper is just accepted recently. I had turned it over to the cardiologist too because we did cardiac MRIs and really elaborate echo studies. And with time, we do see improvement in heart function in these patients. With time, it's much slower, which is amazing, because to me, if you're taking a test for your license and they say, what's the #1 cause of death in scleroderma? I would probably have to write pulmonary. That's wrong. It's cardiac. It's always cardiac. Always. And there are now papers saying exactly that because people weren't studying the heart. Pulmonologists look at the lung. Scleroderma patients are involved in all this tough skin and they look at the lung. They're not studying the heart. And in fact, in the lung, the most common cause of death is pulmonary artery hypertension. And it's not that you suffocate or you drowned. You may end up on nasal cannula oxygen, but you're breathing. That pulmonary artery hypertension causes the heart to stop. Okay, so even in that case, it's the heart. But this disease involves the heart. It's the biggest organ in your vascular compartment. This is an autoimmune vasculopathy. So in the ASSIST trial, the top one is overall survival, and here's relapse-free survival. So 70% never relapsed by 5 years, which is pretty good. But we had some early deaths, 6% mortality, and they were all heart deaths. Now, if you look at the European study in JAMA, you know, they have 10% deaths. And if you look at the Scott trial, they have 10% deaths. The Scott trial had cancers and leukemia and stuff. We never got any of that. The Europeans didn't get that. This is a total body radiation they used. In the Scott trial, the lungs never got better. It's because of the total body radiation, despite lung shielding. With us, we don't use it. The lungs get better. There's no cancers. The Europeans didn't have that problem either. But the Europeans had 10% death because they weren't recognizing heart deaths. And if you look at their study, they say multi-organ failure is a cause of death. No, the heart failed, and then all the organs failed. So I called Dominic up, one of the lead authors. There were 2 first authors. I said, Dominic, these are heart deaths. What you report them as, you know, pulmonary edema. The pulmonary edema is heart failure. This is a heart death. And you report it as multi-organ failure. That's a heart death. And so she looked into it, and she agreed. She wrote a follow-up paper on it trying to clarify. It's a heart death, but if you go to the original JAMA, they don't explain that. Here's the thing. How does it affect the heart, scleroderma? Let me get back to this. It affects the heart, of course, through pulmonary artery hypertension. The right ventricle dilates, and it can just stop. The pulmonary artery hypertension can be very bad. Diastolic dysfunction. The left ventricle itself gets diastolic dysfunction like amyloid. Diastolic dysfunction means if you do an echo, systolic contractions like that, super fast, looks perfect, ejection fraction's great. What they're not looking at on the echo, not reporting, is relaxation, diastolic relaxation. These hearts are stiff, like they're joints. So they can do that, but try to get them to relax, and they can't. The heart's the same way. It doesn't relax well, very slow. If you give those patients fluid fast, it fills up in the left ventricle, backs up in the lung, you got pulmonary edema, you got big problems. So the heart's compromised, now you made it worse. Okay? So it's a diastolic dysfunction. It's a stiff ventricle. Both ventricles are stiff, but especially the left. You get cardiac tamponade. You can get constrictive pericarditis that's undiagnosed. And you can't take a patient through transplant with those things. You have to be on high alert to look at that. And in transplant, they can enter a high output cardiac failure state. It's crazy. I've seen it. What's going on? And everybody's scratching their head. Their hearts are compromised. They have a restrictive defect, yet they're in high output failure with marked pulmonary edema. Why? What's going on is they're shunting in the periphery. Their capillary is already shot. I showed you what the nail bed looks like. And now, in the middle of a transplant, they'll start shunting across from the artery to the vein, skipping the capillaries totally. And the tissue ischemia gets worse. Their blood pressure bottoms out. They're shunting like crazy. They get put on these high-dose pressors. The pressors cause more vasoconstriction. You're making the shunt worse with the vasopressors, but your focus is just bringing the blood pressure up. A lot of these bad scleroderma patients walk around with a systolic pressure of 90 and tachycardia. That's their baseline. So the people in the unit aren't seeing that. So we had to have major fights with the units. And finally, because the cardiologist was on my side, and most cardiologists aren't, because he would see every patient with me. We sat at the bedside, we figured it out. They had him on we call it Levofed. The other name for it is, well, I'm not going to use that name. Levofed and neosynephrine. Very potent vasoconstriction. They're focused on bringing the blood pressure up. We got them to stop the Levofed and the neosynephrine and instead use dopamine and very low dose nitrite. And this is where they fought us. Why are you using a vasodilator? They're hypotensive. It's because the low dose nitrite will open up those capillaries, that shunting will start to stop, tissue perfusion improves, and you get out of it. And we were able to get that patient out of it. But it's counterintuitive to try to get someone in a unit hypotensive put on nitrite. That causes hypotension. We're not trying to cause hypotension. We're trying to stop the intense vasoconstriction. And by the way, the Raynaud's, which is vasoconstriction, you get ulcers, it occurs in the heart. The heart can get Raynaud's and become stunned. And they get Raynaud's and they get fibrosis in the heart, just like they do in the skin. They absolutely do. So we do cardiac MRIs before and look at extracellular volume because it tells us the extent of fibrosis in the heart, and that's why they get these arrhythmias. They have all these fibrotic loci, okay? So they get a ton of arrhythmias. But the arrhythmias don't bother me going through a transplant. If we need to, we put them on amiodarone and let them have the arrhythmias. They're on a monitor, they're used to it. I'm amazed when I see a scleroderma patient talk to them, they never mention they have palpitations or arrhythmia. I have to ask them. They're so used to it. And they say, oh yeah. I say, tap it out, you know. They're running VTAC, you know, in and out, and you can take them through transplant with that. We'll put them on amiodarone. That's the best drug. But when we first started, we would try to go in and have interventional cardiology ablate a foci. But the problem is the foci of arrhythmias arise from intracardiac Raynaud's and fibrosis, microfibrosis. You ablate it, you get more fibrosis, you get worse arrhythmias. Doesn't work. So we just put them on this and we take them to transplant. But this is very important. You have to work those hearts up carefully. You have to know if you dump fluids in them like you would in MS or you would in Crohn's, you're going to put them in heart failure. They're going to die. They're going to go to the unit. They're going to put on these intense vasosuppressors. It's over because they're already clamped maximally and they're not perfusing the tissues because the capillaries are all messed up and now they're shunting. Okay, so be aware, scleroderma patients normally have low blood pressure. Don't overreact. This is normal for them. Look at their chart. They often have tachycardia. They often have arrhythmias. They're walking around like that, and they have peripheral shunting and stiff ventricles. So don't hyperhydrate them. This drug should never be used in scleroderma. It's a very intense vasospasm. It's the worst for a scleroderma patient. If the unit uses it, your patient's going to die. So don't let them do it. For hypotension, dobutamine causes little vasodilation and increased cardiac output. Dopamine if you need for some more vasodilation, and then a very, very low dose nitrile, and you'll bring them out if they have higher output heart failure, which I've seen. Okay, so can HSCT be made more cardiac safe? So first is better patient selection. Well, we would always do a cardiac MRI. Don't do it unless you do it and look at it yourself and know what you're looking for. Okay, and a cardiac cath with fluid challenge. The fluid challenge is very important. You put a cardiac cath in, you get pulmonary artery pressure, mean pulmonary artery pressure, and it looks good. And you give us, but the patient since midnight has had nothing by mouth. And it's an elective procedure, and they're so busy in the cath lab, they'll get to them at 5 or 6 in the evening. So they've been NPO almost 24 hours. Their pressures are going to be, their intravascular volume is dry. Their pressures look okay. You give them a liter of normal saline in 10 minutes and they go sky high. You do it to a normal person, it doesn't change because the pulmonary vasculature opens up. A scleroderma patient, it's a vasculopathy, their vascular is stiff. It won't open up and their pressures go sky high. So you have to do the fluid challenge and you have to know the cutoff ranges, which we have published. I don't have time to talk about. Cardiac MRI, what to look for, we've published, but you can always ask me. Or you could, so the only people scleroderma get upset with me are the ones I'd screen out because I know they're too high a risk, cardiac risk, and you know, they would be very mad. So I decided to do a new conditioning regimen for the high risk cardiac ones to take them through. And we did that by limiting dose of Cytoxan from 200 to just 60, a one-time dose, adding fludarabine, 2 doses of rituximab, and keeping ATG. And it worked beautiful. It took the hardest autoimmune transplant I ever did with the biggest risk going to the unit and dying, 6%, to one of the easiest transplants you can perform. And the reason it did that, you got rid of the Cytoxan injury to the heart, which a normal heart can take well and recover from easily. A scleroderma heart can't. They're way too compromised. And you cut this regimen cut the neutropenia period from 5 to 10 days. You cut it in half, so they just, neutropenia also stresses the scleroderma heart. It turned out to be a really easy, we called it the CASP regimen, cardiac safe transplant. We did 42 patients. That's reported in bone marrow transplant. But this is the way that I would now just do everybody. We initially did these bad heart patients we wouldn't do with a regular regimen, and they've done really good. Now, we don't have long-term follow-up on them. We have 2 to 3 year follow-up. They did great, they're improving. We did have some relapses, but it's low. But it is important. You have to use all of these. Don't not use the rituximab. You just use fludarabine, Cytoxan, ATG. You're going to get a higher relapse rate, and you're going to get secondary autoimmune disorders. The rituximab is very important. Fludarabine gives a lot of secondary autoimmune disorders by itself, and a regimen it also will. But this works very well. And you know, the patients are up walking around bored, which is what I love to see. We're not having fever. We're not having consumption of platelets. We're not having cardiac compromise. All right, so here I go again. California iPS cells kill switch. So I just told you about my book, Everyday Miracles. I hope you have an opportunity to read it. You're going to love it. I've asked to write another book. It's called Kill Switch. I'm on chapter 6. It depends on the time, but I definitely love doing that. IPS, I've switched my lab, my work to embryonic stem cells and IPS, and we have 7 patents in America on our IPS work, and the federal government's awarded us the patents. If you think it's hard to get a paper published, which it is, and you feel like you're in the UFC ring getting beaten up and you get tired of doing it, try to get a patent approved. It is awful. It's a 10-year process of fighting, and they throw everything at you. But once the US government says it's unique, you've got something that you can hold up in a court of law. We were also patenting the same things in Brazil. We have patent attorneys in Sao Paulo, and it's just a slower process here. But we're working on it, and we patented in Singapore as a door to the east. Now, of course, what I've talked to you about today isn't patentable. We never wanted to patent it. We don't want any royalties on it. We just want it to help people. I want to see it go forward. I want to see centers do it. They don't need to come to me. As a matter of fact, I'm trying to spend my time on my IPS technology because we have a technology that I think is going to be the new future. iPS cells we can take any cell and reprogram it to an embryonic stem cell. The embryonic stem cell, in case you don't know, when an egg and sperm are fertilized in the fallopian tube, as it's going through the fallopian tube, it turns into a morula, 4 cells, continues to divide, becomes a blastocyst, which is the pre-implantation embryo. So the blastocyst is this microscopic ball. The outer cells have already differentiated to trophoblasts that will form the placenta. The inner cells, there's about 200 of them, 150 to 260. Each one of those is called an embryonic stem cell, and they'll form every organ in your body, every organ. The whole thing is still microscopic. It's not yet an embryo because it hasn't implanted. As soon as it drops into the uterine cavity and implants in the uterus, then it's an embryo. Until then, it's a pre-implantation embryo or a blastocyst. And researchers have taken, there's ethical issues here, I totally get it. Researchers have taken those embryonic stem cells and they can differentiate them into any cell in your body, okay? That's their power. But normally, the embryonic stem cell exists in all of us. We all had it from day 4 to day 7 after conception, and it disappears. The reason it disappears is its natural strength to form every cell in your body. You need to get rid of it, or it'll continue to do that, and you'll be a giant, disorganized, tumorous mess of all types of cells. And so it differentiates into mesoderm, ectoderm, endoderm, and then those differentiate to your adult cells you're living with today to help repair. But those embryonic stem cells, we can now take, and it was actually Yamanaka that got the Nobel Prize for doing this, but we've done it too, modifying what he's already reported. We can take any cell. We can take your skin cell, any cell. Now, the younger the cell, the easier it is to do it. So we took neonatal foreskin and fibroblasts, culture them up, establish master cell bank, and then we genetically reprogram them. There's a cocktail of genes or mRNA or even small molecules you can use to genetically reprogram it to an embryonic stem cell. And those we've been able to do some amazing things with. I hope someday to come and talk about it. There's no time today to do that. But that's, we're continuing the autoimmune transplants at California. I'm not at the bedside 24/7 like I had always been. I have other doctors involved, thank goodness, because I just can't anymore. And I'm trying to get this going. We're working on various grants and support to make this go forward. And then I do have other things, but I want to get this other book, Kill Switch, out. My last publication, maybe it won't be my last, but I'm thinking my last publication for transplant for MS will be long-term outcome, 10 to 20 years. And I've already put in for a grant because I want to pay the patients for their airfare and hotel because they come from all over so we can do the analysis. There's no treatment. I just want to have a good documentation so it'll hold in the literature as to the duration of these remissions. I don't know if the grant gets funded. If it doesn't, I'll go for another grant. I mean, you just have to be persistent. So that's the key here. Success depends on commitment, persistent, and continuing to take one step at a time, not giving up. And I hope other centers start doing that. It kind of means you're going to have to give up transplant cancer. I did. I gave up cancer totally and focus on this autoimmune world, learn those diseases, and read the literature. I can offer protocols, take what I've done, and if you, after you do it and you think and you study these diseases, you're seeing your patients every day, If you've come up with a way to improvement, good, good. You see how I've done it with time improving. So that's just good. That's how it should be. Thank you. Yes.
The rheumatologist. Actually, you did it fast because you don't have good data. Scleroderma is difficult. I concur with you. From the 89 patients, and I don't know how many they were from Ribeirão, but I know that we tried to put in like 15 patients from our outpatient clinic at the Federal University when I was there. We got 2. The others were rejected. From those 2 died. They didn't do it. They didn't make it. And the other were rejected basically because heart. The problem is you don't get scleroderma on thinking on transplantation when they are normal. You do a right cath or a complete catheterization and they always get pulmonary hypertension, with or without interstitial pneumonitis. So almost all of the patients with scleroderma are off limits, at least. Now you are changing your protocols, so maybe we can get a little bit easier and faster. So I won't, it's already late. Could you please go into a very, it's not the topic, but I'm very interested. You have your data. Even in scleroderma, I still think it's like, we should go forward, but we are not there yet. In the last week, the ACR meeting, the American College of Rheumatology meeting, they gave us the CAR-T first results, 5-year results. 10 patients with scleroderma, 10 remissions. Can you compare the biological, what's the basis for CAR-T versus TMO? Because it's impressive. 10 out of 10, 5-year remission in scleroderma.
So I have a thing here. A couple things to say there. I'm very much aware of the data in Ribeirão Preto. They did do something slightly different. They modified it. They cut the ATG to 5, and I think their patients didn't have quite as good a response. The reason they were screening out bad hearts was because I was telling them you need to do that or you're going to have deaths. But there were definitely a lot of people we treated whose hearts were bad. Believe me, every scleroderma patient, the heart is affected. It's just the extent. And so on the parameters we put with the cardiac MRI and the cardiac cath, we were able to screen the vast majority out, but you could still get some really shaky transplants because they always have an affected heart. So because of the ones that were upset at me when we wouldn't do it, or like you said, you'd send and they wouldn't do it, or because it could still be iffy in some of the patients despite the cardiac MRI and cardiac cath and echo and so forth, I came up with this cardiac safe regimen, and it totally has changed it. It's a very easy transplant now. It's one of the easiest I can do. We don't have the long-term data, but the 2-3 year data is just as good. So only time will tell. As far as CAR T cells, I don't work in CAR T. I'm glad to see, CAR T cells help. They help in some cancers. They've been done in lupus with, significant short-term benefit, and I've heard about it in Scleroderma, I think they're also directed against B cells because it's been found in scleroderma that, of course, rituximab, or anti-B cell therapy, does help. And in fact, in our last regimen, we use ATG and rituximab, lower dose Cytoxan and fludarabine. So I think what I can tell you is you can do them, you can do it a lot cheaper, a lot easier than the way we have been doing them, with a lot less risk. You can even do these bad hearts and they walk through it. There will be limits again, even in our cardiac safe cast regimen. There are limits on the heart, although we never came across it, but there will be limits, and also with pulmonary function. But the vast majority you'll be able to take through. Now, it is cheaper than CAR-Ts. CAR-Ts are really expensive currently. Now, people are working to make it cheaper, and if they can do that, that's going to have a big impact. But right now, CAR-Ts are kind of an academic phenomenon. We're talking $1 million per patient. You know, it's never going to come here. In America, insurance companies aren't paying for it. They're not going to pay $1 million per patient. So CAR-T is a very expensive process. Now, Miltenyi is working on making it a closed system that you can do locally at your center through a new device, and you just add their cocktail to generate the CAR-T cells. If they succeed in that, and if it's as good, that'll markedly decrease costs. It's probably going to be, $300,000. It'll still be very expensive for here. This type of transplant is dirt cheap. Will it be as good? I don't know. But if, as medicine advances, if better things come out, I'm all for it. I want the cheapest, best therapy for any patient. And someday, if someone comes up with just one magic pill, no side effects, and you take it and all autoimmune disease disappear, good. Don't do transplant for anybody. But right now, there's still a lot of patients that can benefit from this approach, including these bad cardiac ones. And CAR-Ts have done some good stuff. Long term, we don't know yet, but they really have done some good stuff. They have a role in treating patients with diseases. They'll continue to have a role. But figuring out how to produce them economically and on-site at each place is a big problem right now. Okay? It's just like my IPS technology. I'd love to come back and tell you, we've done incredible things with animals. I can make animals younger. I can make them more intelligent. I think there's incredible opportunity in patients. For me, that's going to be the new future. It's not CAR-Ts. It's not mesenchymal stem cells for MS. It's not even what I did here with Hematopoietic, which has done great things and should be offered. Tell the next best thing. But IPS for me is going to be the new future. I feel like I was 30 years ago talking about transplant for autoimmune disease, but I had no human data, and people looked at me, I had animal data. So that's where I am now with my IPS work and embryonic stem cell work. But it's really exciting, and again, I'd love to come back here and give you a talk on it someday.
Ok. Bom,
Obrigado.
Muito obrigado.
I can make animals younger. I need to do that for me. So this is me when I was 17. Desiceci. My mother had saved it. I'd long forgotten. So I need to work harder in my IPS work. What happened? What happened is medicine and aging.
Bom, eu gostaria de agradecer, muito obrigado por estar aqui. E acho que uma coisa que passou assim meio en passant na sua discussão, mas que eu acho que é uma ideia muito boa, me entende? É ter um departamento de doenças autoimunes. Eu fiquei imaginando que uma instituição como esta aqui, se tivesse um departamento de doenças autoimunes representado por pessoas de diversas especialidades, pode ser um embrião de uma coisa muito maior, não é? Então, essa ideia, eu acho que pode ser da gente lançar esse embrião aqui no hospital para que os nossos dirigentes pensem numa coisa desse tipo que pode ser realmente um diferencial no futuro. Então, muito obrigado por seu tempo, por ter se disposto a vir aqui.